This lecture will cover women's health, some of the common things that women experience, and then also some different things that are specific just to women's health. The leading causes of death for women are listed on this slide. They include heart disease, cancer, unintentional injuries and accidents. So, driving down the interstate and getting in a car wreck, falling off of superstition when you're climbing it, chronic lower respiratory disease, and stroke. It's really important to provide women information on these different leading causes of death and how they can prevent their chances or risk of them dying from that. Heart attacks in women do present a little bit differently than what we think of a normal heart attack for a male. Their symptoms in women for a heart attack can vary, including they might have an unusually heavy pressure on their chest, sharp upper body pain in their neck, back, jaw. They might complain of severe shortness of breath or cold sweats, unusual fatigue, unfamiliar dizziness, lightheadedness, unexplained nausea or vomiting. In fact, a lot of women will get diagnosed with indigestion instead of a heart attack. For stroke, just some of your other signs and symptoms of a stroke: sudden onset or of numbness or weakness. Usually it's one-sided. They might have trouble seeing because only one eye is working, trouble walking. They might feel dizzy or a loss of balance or coordination. And they could also complain of a severe headache with no known cause. So like I said earlier, we really want to educate the women on ways they can reduce their risk of experiencing these different things that could cause to their death. So providing them education on that is very important. Encouraging them about their diet. We want their diet to be rich in vegetables, fruits, whole grains, fiber, dairy, fish, and low in saturated fat and sodium. They should get at least 3 servings of calcium per day. That can be anything like yogurt, milk, cheese, even broccoli has some higher levels of calcium in it. They should exercise at least 150 minutes per week of moderate intensity exercise. Some examples of that would be walking, swimming, biking, dancing, hiking, anything like that. That exercise really helps lower their risk for heart disease, type 2 diabetes, some different types of cancer, falls, and depression. It can also help decrease their obesity, which is associated with a lot of different health issues. Talk to them about maintaining a healthy weight, minimizing the amount of exposure to UV light, so wearing sunscreen when they're outside, a hat, long sleeves, anything like that. Avoid smoking and secondhand smoke. They should limit their alcohol consumption. Talk to them about preventing injuries from accidents, so wearing a helmet if they're on the bike, stuff like that. Maintain good sexual health, and encourage them to get vaccinations and routine screenings. This slide lists some different immunizations that are encouraged for everyone to get. You really want to provide education on why it's recommended to get immunizations. The influenza should be yearly. These days, the COVID-19 vaccine is now available and should also be done yearly. The pneumococcal vaccine is a vaccine encouraged for people older than 65 years old, or if they have some sort of condition that will weaken their immune system. A herpes zoster for 50-year-olds and greater. A Tdap should be every 10 years. A varicella vaccine, they should have it if they've had no evidence of ever having chickenpox or if they don't have immunity to varicella. And then the HPV vaccine. We're going to talk a little bit more in depth about this HPV vaccine. So HPV, the vaccine helps prevent a patient from developing HPV, which is human papillomavirus. This is the most common sexually transmitted virus in the United States. Okay, I didn't say infection, not an STI, but a virus. HPV is the main cause of cervical cancer and genital warts. It can also cause other types of cancers, cancers of the cervix, the vulva, the vagina, the penis, or the anus. It can cause mouth cancers or oropharyngeal, so your tongue, tonsils, or throat. So a vaccine was developed. You might hear it as the Gardasil or Gardasil 9. It's given IM, either 2 or 3 doses. What the vaccine does is it doesn't prevent the virus from getting transmitted, but it prevents it from turning into cancer. Okay, it forms antibodies to HPV. You still, even if you have the HPV vaccine, you still must get tested for STIs and HPV, okay, because it doesn't prevent it from happening. And it's really recommended to be given before you become sexually active. So that's why you'll see, if you think of your PEDS course, how the HPV vaccine is recommended for like 12 to 13-year-olds, because we want to catch them before they become sexually active to decrease that risk of them developing HPV. Now, this is kind of one of the controversial vaccines that are out there. You might have some parents fight you on giving HPV vaccine to their 10, 11-year-old because they're not sexually active yet or anything like that. Again, you can't force anyone to get the vaccine, but really just to educate them and tell them why it's important, why it's available, what it can help do, and then you might be able to sway their opinion a little bit. Okay, let's dive a little bit deeper into other STIs, or sexually transmitted infections. STIs are primarily spread through sexual intercourse through the vagina, anal, or oral. If you develop an STI, or your patient develops an STI and is untreated for it, it increases their risk for cervical cancer, pelvic inflammatory disease, infertility, in ectopic pregnancy, or chronic pelvic pain. This is why it's really important that we, for sexually active patients, that they get tested for any STIs. They also, if they are positive for an STI, that they get their partner treated, and they use a barrier method to help decrease the chances of spreading it to someone else or contacting it themselves. So we're going to look at some different STIs here on the next few slides. So here's a little graph that talks about some of the more common STIs. We have chlamydia, gonorrhea, syphilis, and trichomonias. Chlamydia is the most common STI. It is caused by a bacterial agent. This is also the leading cause of infertility and ectopic pregnancies. So if you think back to our first modules 1 and 2, if women are infertile, something that we test them for is for STIs. Some symptoms that might make you think a patient has chlamydia would be mucopurulent discharge from the cervix. They could have spotting, lower abdominal pain, nausea, fever. It's diagnosed through a swab test or a urine test. Chlamydia can live in the throat, rectum, and the urethra. Okay, so through different types of sex, it can be spread to different parts of the body. Treatment is through antibiotics, so doxycycline or azithromycin. And again, it's important to also treat the partner. Gonorrhea is caused by a bacteria. Some symptoms of gonorrhea include vaginal discharge, AUB, this is abnormal uterine bleeding. So you're bleeding when it's not that time, the normal menstrual time. Postcoital bleeding, so bleeding after sex. They might have a lower backache, urinary frequency, dysuria, pain with sex. This is diagnosed with a swab too. A lot of times a swab has You can test for gonorrhea and chlamydia at the same time. This will be treated with an IM antibiotic. And again, you want to make sure you're treating the partner also. Syphilis is the next one listed on here. This is this is caused by a different bacteria. Syphilis can have different stages or levels of severity. So your primary outbreak with syphilis is a single painless canker or a little ulcer, which appears about 10 to 90 days after you've contacted syphilis, and it resolves without treatment. Then the next part of it is secondary. This one, if someone has secondary syphilis, they have a skin rash, a fever, a sore throat. They can have muscle aches, weight loss, fatigue. This can appear about 6 weeks to 6 months after they developed that canker. And this resolves within about 2 to 10 weeks or so. Tertiary syphilis is really bad. This is where the bacteria has spread throughout the entire body and it causes damage to internal organs. So way back many, many years ago when people died from syphilis, it was due to tertiary syphilis. They would, so much damage was done to their internal organs that their body could no longer function. So we test for syphilis either through the VDRL or an RPR. If you remember, during pregnancy, we can do these tests. VDRL just stands for Venereal Disease Research Laboratory, and the RPR is Rapid Plasma Reagent. So the RPR is a rapid test, where the VDRL takes a little bit longer for the results to come back. This is treated with doxycycline or tetracycline. Again, treat the partner. Trichomonias. Okay, this one is caused by a protozoan. So if your patient has trich and you grab some of the vaginal discharge that they have and you look under the microscope, you'll see the protozoans moving around in there. These patients can have a profuse frothy gray or yellowish greenish discharge. It has a foul odor. They can have edema, pruritus of the external genitalia. They can have a lot of pain with sex. They could develop some small red ulcerations in the vagina or on the cervix. This is going to be treated with Flagyl. Remember, if a patient's on Flagyl, they need to be educated to not consume any alcohol with it. And again, treat the partner. Okay, so those are like your main STIs, like when you think of really, really bad ones. These next ones we're also going to talk about are other things that can develop. The first one is Candida vaginitis, or better known as a yeast infection. This is caused or occurs because of changes in the hormone levels. So whenever the patient's estrogen level kind of changes, either goes really, really high or drops really, really low, she can have increased risk of developing yeast infection. So like right before or immediately after she has her menstrual period. Another one, high levels of estrogen during her pregnancy. So during pregnancy, women are at a high risk of developing a yeast infection. If the patient has some sort of depressed cell-mediated immunity, so if they're on like corticosteroids for something, or maybe they have AIDS or HIV or something like that, they're at an increased risk of a yeast infection. If they're on antibiotics, diabetes, or menopause, all those things can cause that estrogen level to change, be a little off, causing yeast infections. Signs and symptoms would include itching, irritation, a white cheesy vaginal discharge. Think of cottage cheese. Okay, sorry if I ruined that for you. There's a picture of cottage cheese down there on the slide. They can complain of pain with sex, burning with urination, and if you check the pH level of the vagina, it's going to be low, below 4.5. What are we going to treat them with? Most of the time, these can be treated with an over-the-counter medication like Monistat. They should start with that, and then if that doesn't work, if it's ineffective, the over-the-counter is ineffective, they might need some diflucan, which is a one-time dose that should help them. The next one we're going to talk about is BV, or bacterial vaginosis. This is the most common vaginal infection. Okay. If you develop BV during a pregnancy, it's going to increase your risk of preterm labor and endometritis. Okay, not endometriosis, but endometritis. Risk factors that you might develop BV include having sex with a new partner, having multiple sex partners, sharing any toys, douching, being on antibiotics. It's a change in that flora of that vagina. Signs and symptoms would include a fishy vaginal odor. Can have a thin, whitish, grayish, or like a milky vaginal discharge. Treatment for this includes Flagyl, clindamycin, or Tindamax. UTI, this should be a review from, I believe it should be probably semester 6 for you guys. But UTIs, I also included in here like cystitis or urethritis. Untreated UTIs increases the risk that your patient might go on to develop pyelonephritis, so an infection of the kidneys. So you really want to treat a UTI before that bacteria has the opportunity to spread up to the kidneys and cause further damage. So risk factors: young girls or menopausal, all due to the decreased levels of estrogen. If they have a suppressed immune system, diabetes, some sort of urinary tract obstruction, so maybe they have kidney stones or something like that. Incomplete or infrequent bladder emptying. Okay, so think of your elderly women who maybe can't void or empty their bladder all the way when they go to the bathroom, or they hold it too long or something like that. That can increase their risk of a UTI. Pregnancy increases your risk of a UTI. Irritation caused by sex, an allergic reaction to soaps, or even bowel incontinence can all cause a patient to develop a UTI. What are some signs and symptoms? Dysuria, urinary frequency or urgency. They could feel like they have this sensation that their bladder is full, even if it isn't. Some tenderness in the suprapubic area. Their urine could be cloudy, foul smelling. They can complain of a backache and pelvic pain. They could be running a low-grade fever. And in elderly women, some other things that they might experience would be confusion, delirium. They might be agitated, start hallucinating or seeing things, having poor motor skills and dizziness, falling a little bit. So what they'll do for these women, if they start noticing kind of changes in their normal behavior, is they might do a UA on them to see if they have a UTI. Treatment, if the UA does come back that they have a UTI, is they're going to get started on antibiotics. Usually Bactrim is the one of choice. Some side effects of Bactrim would be nausea and vomiting, diarrhea, and rashes. Okay, so we already talked about the importance of providing education about immunizations and why it's recommended and everything like that. But you also want to provide education to your patients about other routine screenings that are recommended. This one lists just a couple of the more common ones and at what age or how often they should have it done. So the first one listed is the DXA scan, or the DEXA scan. This is a scan they can have done. We'll talk about it later. But if they're at risk for developing osteoporosis, it's recommended to have the DEXA scan done. A mammogram is recommended to start. Different places will tell you different things, but around age 40 or so. We'll talk about that on the next slide. Cervical cancer. This is done or screened for by getting a pap smear done. So a pap smear is recommended to start at around age 19 or 20 or so, or when you become sexually active. And it should be done every 3 years until you reach the age of 30. As long as they've been clear and there's been no issues, then once you reach the age of 30, you can have a pap smear done every 5 years. okay? And that will continue on until you're older. Now, what do you do if your pap smear comes back abnormal? Does that mean that you have, HPV or anything like that? Does it mean you have cervical cancer? No, not necessarily. So an abnormal pap should be followed up with a colposcopy exam with the biopsy. So they'll kind of go in the hole punch, think of it that way, your cervix, where the abnormal cells were located, and they'll look at those cells under a microscope and kind of see what the abnormality is. Is it cancer? Is it just a weird abnormal growth or anything like that? STI test should be performed. Really, it's determined by your risk factor. So how many, are you sexually active? How many different partners? Do you have a history of any STIs? And then all pregnant women should be tested for it, just because STIs can cause so much issues during the pregnancy. Ectopic pregnancies, preterm labor can be transferred to the baby, all sorts of things like that. Okay, let's talk a little bit about breast cancer screening and the mammograms. So early detection of any breast issues provides the best results. So what does that mean? Well, we used to recommend that women do monthly self-breast exams. Research has found that it really hasn't helped decrease breast cancer at all. It is recommended still to teach women different things to assess their breast for and to report those changes to the provider, but it's no longer stressed that, on the first day of every month they have to do this self-breast exam. Women who are considered average risk for breast cancer, okay, just like a normal, no additional risk factors, are recommended to get a mammogram once they get to about the age of 40. So average risk would be there's no family history of breast cancer at all. They've never been told they have the BRCA1 or BRCA2 gene mutation. Now, for women who are high risk for breast cancer, meaning there's a family history of it within their close relatives, they are recommended to have a yearly MRI and mammogram done to detect any of those changes early. Also, women who are high risk, they should get tested for the BRCA1 or BRCA2 gene mutation just to see if they have that gene mutation. If they're positive for that BRCA1 or BRCA2, it increases their risk of them developing breast cancer. There's a website on here that you can go to if you would like, and it's going to help calculate you can put your own information in there, but it will help calculate your risk of developing breast cancer in your lifetime. Prior to your patient getting a mammogram, a couple of things to provide them for education. First of all, if they do have any breast implants, they're going to want to inform their provider about that. That will change kind of how they read the results. And also they'll want to know they'll kind of look into more about where the implants are located and everything like that. Your patient should not wear any deodorant, perfume, lotion, or powder on the day of the mammogram, as that can cause shadowing or issues with the way that the results look. And if anything comes back abnormal on the mammogram, it should be followed up by a ultrasound with a biopsy to be done or an MRI to look for the spreading of any of the cancer cells. Another screening you want to perform on your patients is intimate partner violence screening. So 1 in 4 women do experience intimate partner violence. It can occur in heterosexual and same-sex couples. This can include physical, sexual, psychological abuse or violence. We should screen all women, asking them, do you feel safe? Asking them when they're alone, not around their significant other at all. And then helping them get set up with resources and making sure that, they do feel safe and don't have any issues like that. Some risk factors that a patient might experience in intimate partner violence. So if they have low self-esteem, low academic achievement, so maybe they never graduated high school or anything like that. If they're an adolescent or a young adult, Alcohol and drug use, if they have few friends, and if there's any marital conflict. Some signs of intimate partner violence that you might notice and would get you thinking would be if the patient has repeated non-specific complaints. Okay, like, oh, I don't know, my tummy hurts, but I can't explain why, or oh, my back hurts, or oh, I have a migraine. Okay, overuse of the healthcare system, so they keep coming in to the urgent care or something like that. If you notice an injury on them, they're kind of hesitant or embarrassed to answer any questions about it, or they try to be evasive, so like, dodging the question. You might notice an untreated serious injury. So maybe there was, you noticed their arm or leg is deformed or something like that. Like maybe it was broken at one point, or, I don't know, their shoulder was knocked out of place or something like that, and they never came in for treatment. And you might also notice bruises at different stages of healing, so different colors, some really, really dark, some getting lighter, the various stages of healing. That would just mean they were abused, 7 days ago, and that bruise is now healing 6 days ago. It would look a little bit different. All right. Switching topics a little bit. So let's talk a little bit about, we're going to talk about puberty, adolescent, kind of menopause, like the different things that a female goes through throughout her lifetime. So puberty. The onset of puberty for a female is between the ages of 8 and 13. Now, what happens during this time? That's when they're going to notice or experience an accelerated growth of their body. Their estrogen is excreted and increases. And because of that, they're going to notice breast enlargement. Okay, you might notice breast buds, growth of body hair, so armpit and pubic hair, acne. They're going to have a growth spurt. Their hips are going to widen. And then menarche, their first period, will occur about 2 to 2.5 years after they begin puberty. Okay. Puberty is complete once they develop a regular menstruation pattern. So their period is going to be kind of irregular at the beginning, but after a few months or so, it should become regular. And then that's when we can say, okay, you're no longer in puberty. Then they become an adolescent. Adolescents, usually we refer to this between the ages of 12 and 19. Adolescents have some health problems that they're at an increased risk for during this time. So menstrual disorders. So maybe they are have a really heavy period, things like that, if that's the case. Or if they have really bad cramps or anything like that, they might get started on some birth control to help deal with the discomforts of their menstrual cycle. Acne can become really bad. If that's the case too, they might need some hormonal therapy to help with this. Eating disorders are common, so think of obesity to anorexia and bulimia, STIs, teen pregnancies, self-esteem issues, mental health issues, depression, anxiety, unintentional injuries, suicide, and homicide are very can be common in this age bracket. Now we're going to go a little bit later in life to menopause. Menopause is split up into 3 different phases. We have perimenopause, actual menopause, and then postmenopausal. So perimenopause is the time when women start to experience or begin to experience menopausal symptoms. So it usually begins in the 40s and lasts about 4 to 8 years. During this time, their periods start to become irregular. Initially they might become a little bit more frequent, or maybe this month we're 4 weeks apart. The next time I get my period is 2 weeks. It's just irregular, but eventually it will space out. And once the female goes 12 months without a period, we can now say she's officially in menopause. The average age for menopause to occur, so when their periods are all done, is 51. After she's been in menopause now. Now we refer to it as postmenopausal, the time after menopause. So, what are some signs and symptoms of menopause? Well, like I said, irregular periods, hot flashes. This is the most common symptom. So when you, like, all of a sudden the patient is just like, oh my God, it's just so hot in here. Like, I don't know why. You want to, if they're complaining of that, talk to them about if they know what triggers them to have a hot flash. Are there certain things like a warm room, alcohol, hot foods, spicy foods, caffeine, stress? If they can pinpoint what's causing their hot flashes, teach them to stay away from that trigger. Other signs and symptoms of menopause would be night sweats. So basically that's a hot flash during your sleep. Sleep disturbances. So either they can't fall asleep or they're waking up a lot. Something is changed in their sleep pattern. Sexual dysfunction. So a decrease in desire or arousal. Vaginal atrophy. This is due to low estrogen. You're going to hear estrogen is the hormone that causes a lot of this bad stuff to happen. If that's the case, they can get prescribed or take some estradiol cream. Women in menopause might complain of psychological side effects like mood swings, irritability, anxiety, lethargy or lack of energy. They might be more forgetful, like, where's my keys? I can't find anything. Depression. They can start experiencing thinning of their hair or hair loss. They might be craving food, complain of dry skin and weight gain, and they could develop an irregular heartbeat and palpitations. So what are we going to do for these? Okay, sometimes all it takes is just some lifestyle changes. So encourage them to get 8 hours of sleep. Talk to them about a balanced diet and getting that BMI to be normal. Encourage them to exercise. Avoid caffeine, alcohol, smoking. Sometimes the lifestyle changes, like I said, are enough. Otherwise, there's some alternative medicines that are available that some women feel like really help. The jury's out there yet on if they truly do or not, but there's some different herbal supplements, acupuncture, biofeedback, hypnosis. Some women say they work, some don't believe in it at all, but it's worth a try. And if their symptoms are causing them a lot of stress and they've tried the lifestyle changes and it isn't working, they might need some menopausal hormone therapy. So MHT, you might hear this referred to. So we have two different ones. We know that these issues are due to a low estrogen level, so we need to give them some estrogen back. Now, if you think back to our postpartum module when we talked about what type of birth control women could have, remember that women with clotting issues couldn't take the combined contraceptive, the one with estrogen. Okay, so we're going to talk about some people that these hormone therapy is contraindicated for. But if the woman has had a hysterectomy and she does not have a uterus, okay, there's no uterus in there left, we can prescribe her just estrogen. Okay, but if she does still have a uterus, then we're going to prescribe her the combined one, the estrogen plus progesterone. The progesterone here is going to help reduce her risk of developing endometrial cancer. The dosage of these menopausal hormone therapy drugs is going to be based on the severity of her symptoms. You should only take them as long as needed, just because there's a lot of bad side effects that can occur. Women with any of these contraindications should not take the menopausal hormone therapy. So unexplained vaginal bleeding, liver or gallbladder disease, blood clotting disorders, a history of a PE, untreated hypertension, or uterine or breast cancer. Okay, uterine is also endometrial cancer. Because that estrogen, again, is associated with increasing blood clots in the patient. So something that kind of goes along with menopause or even postmenopausal is sexual health. So I kind of talked about the estradiol cream before, but with that declining levels of estrogen, how it can affect the patient's sexual health is it can lead to vaginal dryness, burning, irritation, itchiness, vaginal discharge, or pain with intercourse. Their libido can also be decreased due to those low levels of estrogen, and their testosterone drops. So what can we do, or how can we help them with that? Educate them on using a water-based lubricant. There's vaginal moisturizers that they can use. There's estrogen vaginal cream, and they can increase the amount of soy flour and flaxseed that's in their diet. All right, next thing we're going to talk about is osteoporosis. So what is osteoporosis? It's a loss of bone mass that occurs. So you'll see here in the picture that you have your normal looking bone there with some little kind of like holes, right? That's how it's supposed to look. And osteoporosis, the bone mass, or there's more openings or holes in the bone. Some signs or symptoms that would make you think your patient might have osteoporosis would be they complain of back pain. They have a loss of height. So maybe you know, last year they were, I don't know, 5'8". They come this year for their yearly appointment and they're 5'7.5". Okay, it could be due to that loss of that bone mass. Their posture can become more stooped or hunched over. They could have frequent bone fractures. Osteoporosis makes those bones less solid and more easily, they can break more easily. So osteoporosis can be diagnosed by the use of a DEXA scan or a dual energy X-ray absorptiometry. Okay, DEXA sounds better. And this will look at their T-score. So a T-score of -2.5 or below means they have osteoporosis. A little bit better than that would be a T-score of -1 to -2.5, and that means they have osteopenia, which means it's a lower level, right? We're decreasing that bone mass, but it's not quite severe enough to be osteoporosis. So what puts women at risk for developing osteoporosis? Well, white women. Here's one of the things that white women are at a higher risk for. The thin, small-boned women. If there's a family history of hip fractures, current smokers and inactive lifestyles increases your risk of osteoporosis. A deficiency in your calcium and vitamin D intake. Consuming more than 3 alcoholic drinks per day. Medications, so example, corticosteroids, if you're on them longer than 3 months, can increase your risk of osteoporosis. Aromatase inhibitors and proton pump inhibitors. A BMI of 20 or less. So these would be, you know, like your skinny little girls, women. History of eating disorders like bulimia or anorexia, or history of weight loss surgery. So if they had a, you know, not just like the mommy makeover where you remove that extra skin from having babies, or if you've, you know, lost a lot of weight, but this would be like stomach stapling weight loss surgeries. You want to educate your patients about ways they can reduce their risk of osteoporosis. So encourage them to eat a diet high in calcium and vitamin D. So they should have about 600 to 1,000 units of these per day. They can get calcium through like canned sardines, which sounds disgusting to me. Yogurt, cheese, milk, salmon, those all have high levels for them. Encourage them to do those weight-bearing exercises 3 to 4 times per week. So walking, jogging, dancing, you know, lifting weights, things like that. Encourage them to not smoke and not be around that secondhand smoke, and to limit their alcohol use, their alcohol intake. But if they do go on to develop it, there's a couple different medications that we can give them. Bisphosphonates is the first one here, and what this does is it inhibits the reabsorption of bone. So it helps keep them from losing any more of that bone density. There are some bad adverse effects that some women don't like. It can be musculoskeletal aches and pains, GI irritation, esophageal ulcerations. An example of this bisphosphonate would be alendronate, or Fosamax, you might have heard of it. Important things about Fosamax, you really need to teach them about ways to take it. Because of those esophageal ulcerations that can occur, it's important that they take it to decrease the risk of that occurring. So they should take it in the morning on an empty stomach, about 30 minutes before they're eating any other food. They want to take it with 8 ounces of water and remain sitting or standing when taking it and afterwards. 30 minutes later, then they can, lay down or anything like that. But that will help decrease their risk of any of those adverse effects from occurring. Some other medications they might try, raloxifene is one, or Evista. This is an estrogen receptor modulator. This helps by binding with estrogen receptors. There are adverse effects with this one too, like VTE, leg cramps, and death from a stroke. Hormone therapy can be used, like Premphase or Premarin. So your Premphase has estrogen and progesterone in it. Okay, so that would be prescribed for women with a uterus. Premarin only has estrogen. That would be prescribed for women without a uterus. And so those are some more options for osteoporosis. Some other newer meds that are coming out, Prolia is one of them. This is used in patients who can't take the bisphosphonates, so maybe their kidney function is poor. Some of their common side effects are listed there. Forteo is another one. Something else related to women's health is the women who identify themselves as LGBTQ. These women experience some health disparities related to the societal stigma. They can be discriminated against. They can even have denial of basic civil rights, which can affect their health care that they receive, or maybe it's not high quality health care that they receive. Some of these women will have a lack of insurance. So if they're married, their spouse's insurance might not accept same-sex marriage, therefore not being able to cover them as a spouse. These patients can also have a fear of a negative reaction from their doctor. So maybe they've, had the same family practice doctor their whole life, and they're scared of what their doctor will say or how they will react when they tell them, that this is how they identify. They could risk, or they could fear their confidentiality. Are people going to talk about them behind their back or anything like that? So there's a lot of barriers that they experience. These patients also tend to go to their doctor less often or less frequently, and they wait until later on. Therefore, if it's something that could have easily been cured or taken care of earlier on, or once it was first noticed, now they wait until later and it's gotten severe, and especially if it's cancer or something like that, that might mean that it is now a stage 3 or stage 4, something more serious. These women are at a higher risk for breast cancer, cervical cancer, endometrial, and ovarian cancer. We're going to talk about all 4 of those later on. And this is due to high rates of smoking, alcohol use, and obesity within women that identify this way. They also can experience a higher risk of PCOS, or polycystic ovarian syndrome, osteoporosis, heart disease, tobacco, alcohol, and substance use, and domestic violence. Something to keep in mind with patients who are in the LGBTQ community is that make sure to include their significant other or their spouse in the education, in the teaching. Treat them the same, just like you would, if it was a husband and wife or anything like that. Here lists some common menstrual disorders that can occur in women. I'm not going to go over all of them with you. I will kind of talk about some of them here, but I would recommend knowing these and what the difference is. So primary and secondary amenorrhea. So primary amenorrhea means you haven't had your period. Primary means basically you've never had your initial period. So this occurs if you get to the age of 16 and you haven't had your period, and you also have no secondary sex characteristics, meaning no breast buds, no hair growth, no widening of the hips, anything like that. Or if you reach the age of 13 and you have those sex characteristics, but you still haven't had your period, that's considered primary amenorrhea. Now, it will talk about how to manage it and what can cause it. That's listed on this slide here. Secondary amenorrhea means that you've gone 3 months without a period. So think of like women who experience PCOS, an athlete who's training for something. Okay, if you're really increasing your muscle mass and everything like that, that can cause secondary amenorrhea. The next one here, abnormal uterine bleeding. This can be chronic or acute. Chronic means that it's lasted, it's abnormally lasted like this for 6 months or more. Acute means it's just kind of one time of a heavy bleeding in between when you or when the patient normally has her menstrual cycle. Anytime you have abnormal uterine bleeding, you need to rule out cancer. So these patients, this is something that should be reported to the provider, and they should be looking for the different types of cancer, cervical, uterine, ovarian, anything like that, to see if that's what's going on. Dysmenorrhea, we have primary and secondary. Primary dysmenorrhea, this is a painful bleeding, painful time during the period. Primary means that the pain begins about 12 to 24 hours before the onset of their menstrual cycle and lasts about 12 to 24 hours. These patients can have chills, nausea, vomiting, headache, irritability, diarrhea. It's really due to an excessive production of prostaglandin. So we could manage that by some prostaglandin inhibitors like ibuprofen, heat, warm bath, exercise, even oral contraceptives to decrease how much bleeding or how often they're having their period. Secondary dysmenorrhea is painful menstruation. It can happen at any time during the cycle. So this can be due to endometriosis. Maybe there's some pelvic adhesions going on, pelvic inflammatory disease, cervical stenosis, fibroids, anything like that can cause secondary dysmenorrhea. And then, of course, we have lovely PMS. This is a combination of emotional and physical symptoms like lower abdominal pain, bloating, weight gain, breast tenderness, diarrhea, constipation, nausea, vomiting, acne, cravings, headache, mood swings that women can experience right before they get their period. It's unknown what causes this. They think it might be due to some hormonal changes or imbalance between the estrogen and progesterone. Again, oral contraceptives might be prescribed to help with the issues with this. Okay, we're going to talk about, this is going into now the last chapter of the book. So I'm going to kind of breeze through some of these abnormal things that can occur to women. So the first one is chronic pelvic pain, or CPP. This is pain in the pelvic region that lasts 6 months or longer. And the pain causes some functional or psychological disabilities. Okay, so it's affecting the patient and her life. They can complain of uterine or abdominal cramping, a sharp pain or a steady pain. The pain can come and go. It could be pressure or heaviness deep inside the pelvis. They might have pain with intercourse or even with a bowel movement. When you think of where your pelvis is located or what's all around the pelvic area, I mean, that's like the center part, the core part of your body. So anything could really cause chronic pelvic pain. It could be something due to the, reproductive. So pelvic inflammatory disease, I can't say that word. So think of it like a cyst, adhesions, endometriosis. It could be due to something urological, so in the bladder, musculoskeletal. Okay, maybe they have poor posture. So they say sitting like slumped over, like what you might be doing right now. Or if you're like me and sitting at a desk slumped over, I'm going to sit up because I do not want to experience chronic pelvic pain. It does not sound like it's a fun thing. Other things, it could be GI like Crohn's or celiac, neurological, psychological, and even due to some sexual or physical abuse. So lots of different things can cause this chronic pelvic pain. What are we going to do? We're going to treat it with, try to figure out what's causing it, right? Treat the cause. You could talk to them about pain management, some hormone therapy, antibiotics, steroids. They might need surgery, change in nutrition, psychotherapy, or even some alternative medicine. So really it depends on what's causing it, and then treat that cause, and then hopefully that chronic pain will go away. PCOS, we talked about this a little bit way back for exam 1, but it's polycystic ovary syndrome. So basically, when you look at your ovary, you have a whole bunch of different little cysts on the ovary. It's due to an overproduction of androgen, so hyperandrogenic disorder. In order to be diagnosed with PCOS, the patient must have 2 of these 3 features. So a clinical or biochemical androgen excess. So you're checking their levels of androgen and it's, excessively high. They either have oligo-ovulation or anovulation. So that means that they never ovulate, okay, or it's really irregular. So maybe they go a few months without ovulating. And then they can also do an ultrasound and they could see the extra cysts or the polycystic ovaries. So 2 out of those 3 things would get you diagnosed with PCOS. Some signs and symptoms that your patient might be experiencing or have PCOS. Infertility. This is a lot of times where it gets diagnosed. They've been trying so long, they just can't get pregnant. It could be due to PCOS. They might have menstrual disorders or abnormal uterine bleeding. Hirsutism, that's facial hair, okay? Kind of think of like facial hair growth like a man. The ovarian cysts, obesity goes along with this. Oily skin and acne, they can have pelvic pain and alopecia. Women who are diagnosed with PCOS, they're at a higher risk to develop other things throughout their life. Diabetes is a big one. So women should be encouraged to monitor their blood sugar levels. I mean, it doesn't have to be, every day or anything like that, but every now and then they should be checking it to make sure that they're not starting to develop diabetes type 2. They're at an increased risk for cardiovascular disease, hypertension, different cancers, infertility, we already said, birth complications, sleep apnea, metabolic syndrome, and depression, anxiety, and binge eating. So what are we going to do for these women? Well, really what we want to do is try to get that high level of androgen to decrease. So we're going to talk to them about diet and exercise, really helping them lose weight, get their BMI to a normal level. This weight loss will help decrease those levels of the androgens throughout the body. They might get started on some low-dose hormonal contraceptives. Okay, that can help with everything too, but now if they're trying to get pregnant, obviously we wouldn't want to give them contraceptives. We can also give them anti-androgen meds. Okay, so these are medications that are going to drop those androgen levels. These are not to be used though if the patient is pregnant or planning on becoming pregnant. So one of these is like Vaniqua. You might have seen a commercial for that helps reduce facial hair in women. These women might need Clomid if they're trying to get pregnant, and again some diabetic meds since it kind of goes hand in hand with the PCOS. Okay, our next thing that women can experience is endometriosis. So we've talked about endometriitis, which is an infection of that lining of the uterus. Endometriosis is different from that. This is a chronic inflammatory disease in which the endometrial tissue, so that lining of the uterus, starts growing in other areas outside of the uterus. It can be anywhere within the abdominal cavity. So it might be on the ovaries, it might be on the fallopian tubes, the cervix, the vagina, the intestines, all sorts of things like that. This is estrogen dependent. So each month when you have your period, okay, you release that endometrial lining. So endometriosis, now that that lining has, grown bigger and outside and everything, all that needs to build up, break down, and be shed. So these women can have very painful, heavy periods. Okay, endometriosis, since it's related to estrogen because that's what helps you have your period. It's estrogen dependent, so it's most commonly going to occur during your reproductive years where that estrogen changes. The cause of endometriosis is unknown. Okay. A third of people who have endometriosis are asymptomatic. They don't even really know it or have any of these symptoms. But other symptoms that patients might experience, pelvic pain and dysmenorrhea, usually starts a few days before they start their period, and it will stop once their period ends. They can also have lower back pain, sharp pelvic pain or pressure, infertility again, dysmenorrhea, abnormal uterine bleeding, diarrhea, constipation, blood in their urine. Their uterus could be retroverted, and they might have enlarged and tender ovaries. So how are we going to treat it? Pain meds, hormonal therapy. So the goal with this is to suppress the menstruation. So if we can keep their estrogen levels, instead of going up and down and releasing of that lining, that will really help with the pain and the growth of that endometrial lining. So they can be started on oral contraceptives. Another thing they can be started on is neferilin or Synarel. This is a GnRH agonist. This can help with it. There are some side effects to this though. Hot flashes is a big one that these women complain about. Emotional instability, headache, vaginal dryness, or acne. They could also be started on some progesterone or progestins. If the hormonal therapy doesn't work, they might need surgery. So during surgery, they could, a laparoscopic one to remove all the lesions where they're growing from. And if they're done with children and maybe they're a little bit older, they might opt for a hysterectomy to remove the uterus itself. Again, if they're trying to get pregnant, these women might need to have some assistance to be able to reproduce. The next one here is uterine fibroids. Again, that's a word, leiomyoma, I believe, of the uterus, also known as uterine fibroids. These are benign fibrous tumors that grow within the uterine wall. They're kind of more of just like an annoyance, and they get in the way of everything. It's the most common tumors found in women. They are sensitive to estrogen and progesterone. So during the reproductive years of a woman's life, these tumors can increase because of the estrogen levels. Risk factors for these women, early menarche, so they're going to get, or risk factors that you would develop this, is experiencing early menarche, so they get their first period really early. Heredity, African American, and obesity. Here's a picture of what they might look like. These women can complain of pelvic pressure just from that tumor or that mass growing. They could have dysmenorrhea, abnormal uterine bleeding, pain in their pelvic area, backaches or leg pain. They might need to go to the bathroom a lot just because that tumor could be pressing on that bladder itself. Sometimes you can feel these tumors. I know a patient of mine once, she was pregnant in labor, and I was doing my Leopold's maneuver, and what I thought was the fetal head was really a huge enlarged tumor that had grown, because what happens during pregnancy, your hormone levels, right, increase. So this tumor not only had hormonal changes to help it grow, but the increased blood supply to that uterus was making this tumor grow really fast. How we're going to manage a patient with the tumor, we're going to do an ultrasound to confirm it. She might need a blood transfusion if something happens, if that ruptures or breaks off. A lot of them will shrink after menopause where that estrogen level drops. There's some medications. They might undergo a uterine artery embolization. So basically, they cut off that, they cauterize the blood supply to the tumor there, or to the uterus. They could do laser surgery, a myomectomy, or a hysterectomy to remove their uterus itself too. Ovarian cysts are cysts that grow in the ovaries. They can contain fluid, blood, or cells. Most will disappear on their own. They'll either reabsorb or they'll rupture and the body will reabsorb it. There's a couple different kinds. There's the follicular or the corpus luteum. What we get worried about though is if they rupture and they start having some internal bleeding due to it. It can rupture during coitus, exercise, if they have some sort of lower abdominal trauma, so maybe they got hit in their belly, or even during a pelvic exam. These women complain of sudden and severe abdominal pain. If that's the case, they might need surgery to help stop the bleeding, and they might even need a blood transfusion if it gets bad enough. These patients, if it hasn't ruptured yet or anything like that, they can be started on some NSAIDs to help with the pain. Oral contraceptives can help them from developing them. They might need surgical removal. But it's also really important for these patients to rule out that it's not ovarian cancer. That's just a cyst and not a cancerous tumor. Okay, pelvic organ prolapse. Okay, this is where the organs within the pelvis just kind of get weak and wimpy and fall down where they're not supposed to be. So some risk factors that you might experience or that a patient might experience a pelvic organ prolapse would be a history of vaginal deliveries, large for gestational age babies that they delivered, if forceps or vacuums were used during a vaginal delivery, poor suturing if they had a laceration or an episiotomy, any pelvic trauma, stress or strain from heavy lifting, constipation or violent coughing, obesity, because that puts extra stress or weight on those pelvic muscles, and also during menopause. There's low levels of estrogen throughout the woman's body, causing everything to become weak and wimpy. So the different types of organ prolapses. The first one is a uterine prolapse. This is where the uterus descends into the vagina. Sometimes if it's a really bad uterine prolapse, you can see the uterus protruding out of the vagina, okay? They might complain of a lower backache, a sensation of heaviness in the pelvis, or that they might even feel like, oh my gosh, my uterus is falling out. Now, I don't know what that would feel like, or if I would ever explain a feeling I have as my uterus, but I guess some people do. They might also have difficult or painful intercourse. So there's a couple different treatment options. A pessary, that's a picture here on your slide. It's like a little, almost like a diva cup in a way, but it gets placed inside the vagina and it's held in place behind some of the anatomy. And it stays in place and it helps hold that uterus up where it's supposed to be. So it's non-surgical. It can stay in place for a while, okay, like days or so. And that's an option. Another option would be surgery. And with surgery, what they're going to do is they're going to lift that uterus back up to where it's supposed to be and tie it there, okay, or potentially even a hysterectomy if that's what they're thinking. Cystocele and rectoceles. So this is where the bladder or the bowel get weak and wimpy and hang where they're not supposed to be. So cystocele would be an anterior prolapse. Okay, it's in the front of the patient. This is where the bladder is now prolapsing or hanging into the vagina. A rectocele is posterior, and that's where the rectum is now hanging or protruding into the vagina. The pessary can be used again here for the bladder one, to help hold that where it is. These women might be started on some estrogen therapy to help improve that muscle strength, that pelvic muscle strength. They might need surgery. Kegels are encouraged, especially starting at a younger age before you actually develop this, to help increase the muscle and strength of the pelvic muscles. Kegels aren't going to fix a cystocele or rectocele, but they can help keep it from getting any worse. Encourage patients to prevent constipation, so a stool softener, increase fiber and increase fluids, and to avoid heavy lifting, as this can all cause a cystocele or rectocele to form. Urinary incontinence, this can happen as women age. So they might complain of stress incontinence, so leaking of urine, when they cough, sneeze, laugh, or anything like that. Risk factors that a patient might experience urinary incontinence would be a history of childbirth, aging, again, due to decrease in their estrogen, obesity, and smoking. So if a patient is complaining of that, we can talk to them about bladder training. Okay, so kind of training their bladder to be able to hold that urine a little bit longer. Encourage them to do scheduled toilet trips. So, every 2 hours, just go to the bathroom. Kegels can help with this, medications, a pessary, or they might need surgery. You can also talk to them about decreasing their caffeine intake and their alcohol use, as both of these things can increase the chances of this occurring. There's some medication listed on here too that she could be started on. All right, a vaginal fistula. This is where there's an abnormal connection between the vagina and either the bladder, the urethra, or the rectum. So when this happens, either feces or urine has a pathway to get to the vagina itself. These vaginal fistulas can develop from a traumatic delivery. Okay, so let's say she tore really bad, or forceps or something like that. If she experienced some sort of pelvic surgery or radiation on her pelvis, any weakened tissue, violent coitus, or sexual abuse can cause a vaginal fistula to form. A small fistula can usually heal on its own with like vaginal rest, but surgery might be needed to fix it if it's severe enough. Really encouraging, if a patient does have a fistula, a stool softener, again, so they're not straining, and increase their fiber in their diet. Okay, breast disorders. Breast disorders. This is talking about kind of signs and symptoms of breast cancer. So those are pictured over here. Any abnormal finding that a patient finds or thinks they might have related to changes in their breast needs to be reported to their provider so they can rule out cancer. So things that should be reported: a change in their skin color of the breast area, dimpling of the skin, or like orange peel, I think is a way that you might have heard it talked about before, bloody discharge from their nipple, feeling of a lump on their breast or even up higher into the armpit area, kind of where their lymph nodes are. A change in the appearance of their nipple, so maybe it starts like pulling in a little bit. Not all these things means that it's breast cancer. I mean, it could just be a cyst or a fibrocystic breast, but it's something that they need to rule out and make sure that it's not breast cancer. Breast cancer is the second most common type of cancer in women in the United States. There's a higher rate in African Americans, but their prognosis improves with early detection and treatment. So it's really important, if a patient thinks they're feeling something or notices a change, to go in and get screened to see if that's what's going on. So other risk factors that increases a woman's risk of breast cancer include her age. So Ashley, gets older. A BRCA1 or BRCA2. So these are genes that you can be tested for. If you are BRCA1 or BRCA2 positive, it doesn't mean you have breast cancer, but it means that you're at a higher risk for developing it, and you should be screened more frequently. If there's a family history, if you have dense breasts, the use of hormonal birth control can cause breast cancer. If you've never breastfed before, it can cause increase your risk of breast cancer. Exposure to head or chest radiation, excessive weight, so think of obesity, exposure to estrogen through early onset of menarche, late menopause, or hormone therapy, and then excessive alcohol use. It can all increase your chances of breast cancer. This next slide here just kind of tells you how it would play out if they notice anything at all, the biopsy and stuff like that. If it does come back that it's breast cancer, what are they going to do? There's a couple different surgeries. There's a lumpectomy where they just remove the tumor or the mass, or there's a mastectomy. That's where they remove the breast tissue and sometimes as much as the lymph nodes. Radiation and chemo can be used. There is some hormone therapy like anti-estrogen medications. So we're going to try to drop that estrogen. This is called tamoxifen. Tamoxifen, not only it's like chemo, right, that they're going to use for breast cancer. Not only can it be used once they're diagnosed with breast cancer, but it can also be started if patients are at an increased risk for developing breast cancer. But it comes with its own side effects, right? Pulmonary embolism, stroke, uterine malignancies. So now maybe they won't have breast cancer, but now they might develop uterine cancer. It can lead to vaginal dryness, hot flashes, joint pain, leg cramps, and nausea. Radiation side effects. So anyone who undergoes radiation, not just for breast cancer, but for any type of cancer, this one talks about some of the side effects and ways to help deal with the side effects. So like diarrhea, they should try to drink 8 to 12 cups of clear liquids, eat small frequent meals. They can take Imodium for that. Fatigue, sexual fertility changes, just kind of review this slide. Other side effects, bruising, anemia, lots of bad things that go along with radiation that you really need to teach your patient about how to deal with them. Chemo has its own side effects, anemia, appetite changes, bleeding problems. So talk to them about using an electric shaver, wearing shoes all the time, a soft toothbrush, avoiding constipation, and about how it can kind of make changes to their mouth and throat depending on how they, depending on how their side effects are. Okay, cervical cancer. Cervical cancer can be detected through a pap smear. Okay, so you go in for a pap smear, and let's say something comes back abnormal on the pap. Now, it doesn't mean you have cervical cancer, but they need to rule out and do additional testing. So after an abnormal pap, they're going to want to do a colposcopy with a biopsy. So they're going to hole punch the cervix, get some of the actual tissue with the cells in it. Remember, HPV is the primary cause of cervical cancer. It's usually really slow growing and begins with dysplasia. So it's precancerous at this point, 100% curable if we catch it early enough. Risk factors that a patient might develop cervical cancer, well, if she's infected with HPV, okay, that can go on to cause cervical cancer. Early onset of sexual activity, if she's a smoker, a weakened immune system, multiple sex partners, okay, the more often they have sex or the more people they have sex with, the increased risk of getting HPV. If they were exposed to DES in utero inside their own mom when they were a fetus, use of oral contraception for greater than 5 years, and also if they've given birth to 3 or more children. So what are some signs and symptoms? Vaginal discharge, leaking of urine or feces from the vagina, so it could cause like a fistula to form, abnormal uterine bleeding or abnormal vaginal, pain with going to the bathroom, loss of appetite or weight, fatigue, back or leg pain. What are we going to do? Again, I said we're going to do that biopsy. Then they're going to do either like an MRI or a PET scan to see how far it has spread and where else they can find it. Treatment, conization or cryosurgery, they're going to freeze or take out that part that has the abnormal cells in it. They could do, if the patient is a candidate for it, a total hysterectomy, radiation, and chemo if it's metastasized or if it's a reoccurring cervical cancer. Uterine cancer here, or endometrial, it's the same thing. This is where there's cancer within the uterus. Okay, so one of those tumors comes back as cancerous. So they're going to want to do a biopsy to confirm it. Risk factors that a patient might develop uterine cancer if she's on menopausal hormone therapy. Okay, so remember before when we said, if you have a uterus or if you don't, what type, if you should take progesterone with it or not. Okay, that's where this goes hand in hand with. Early menarche or menopause after the age of 52, so they've been prolonged or had their period for a prolonged amount of years. Obesity, use of tamoxifen, so the tamoxifen was used for breast cancer, now we're increasing our risk of uterine cancer. Nulliparity, so they've never been pregnant, or diabetes. So uterine cancer can be staged. There's 4 different stages, 1, 2, 3, and 4, depending on where they find all the cancer cells, as it's spreading or not. For example, stage 1, it's just found in the uterus. Stage 2, it's found in the uterus and also started going down into the cervix. Okay. Stage 3, it's outside of the uterus and kind of like in the area outside of that. And then stage 4, it's throughout the body. What are signs or symptoms? They might have, the most common sign is postmenopausal bleeding. Okay, so they went through menopause, now all of a sudden they're bleeding again. What's going on? They need to rule out uterine cancer. They could have abnormal vaginal discharge, difficult or painful urination, pelvic pain or pressure. Again, there's different stages like I listed on the last slide. And treatment is going to be surgery, radiation, chemo, possibly hormonal therapy like progesterone, and target therapy would be targeting the type of cancer that they have. Okay, we're almost done, you guys. Ovarian cancer. This mainly occurs in postmenopausal women, like your elderly. They're very vague symptoms. Okay, like they can't pinpoint something. It's just vague. Like, I don't know, something just doesn't feel right. Risk factors that a woman might experience ovarian cancer: if there's a family history, if she's over the age of 55, obesity, if her first full-term pregnancy occurred after she was 35 years old, or if she never carried a baby to term. Use of infertility drugs for over a year, and if she's tested positive for BRCA1 or BRCA2. Again, there's 4 different stages of ovarian cancer, kind of just like all the cancers. The treatment is going to depend on which stage they're in. It could be a total hysterectomy with a bilateral cell-ping oophorectomy. That means they're taking the uterus, the tubes, and the eggs. Okay. Could also be treated with chemotherapy. This lists here kind of some of the vague, unexplained fatigue, unexplained weight loss, bloating. It's just kind of really random, vague symptoms that it could be ovarian cancer. So those last 3 cancers, the ovarian, uterine, and cervical, something that might be recommended for surgical treatment is a hysterectomy. So this is the removal of the uterus. Common reasons to have a hysterectomy done is for fibroids, endometriosis, prolapsed uterus, or again, cancer. There's listed on here different types of hysterectomies depending on how much of the uterus they're taking out or leaving. That's just there for your information. There's also different ways they can do a hysterectomy. They can do it abdominally, so they take it out through the abdomen. They can do a vaginal hyst where they take the uterus out through the vagina. There's laparoscopic or robotic. There's lots of different ways, and depending on the reason why they're taking the uterus out or how much they're taking out will help determine which one they're going to use. Now, this is a surgery and there are risks. So there's complications related to anesthesia, so them getting put to sleep. There's potential for injury to the ureters, the bladder, or the bowel. That's all right around where this is, right? They could hemorrhage, they could develop an infection or a DVT or a VTE. So preoperatively, what do you need to do? These are usually scheduled surgeries. Okay, it shouldn't necessarily be like an emergent surgery like when we're thinking of during labor. So these patients, it should be scheduled. They should be NPO for at least 8 hours before. You're going to want to review their history, do a good physical assessment on them. The provider might order an EKG beforehand to make sure their heart is okay and can handle surgery. Review that consent was signed antibiotics for them, any labs that need to be done. There should be a surgical checklist. Make sure everything's done on that. Get an IV. The Foley catheter will get placed, and really emotional support. Okay, so if this is let's say this is a younger lady. Okay, let's say a 30-year-old who just got diagnosed with cervical cancer and she's going to get a hysterectomy. There's a lot of emotional things that go along with this. Okay, think if she's never had children yet, or she was hoping for more children. Well, she's not going to be able to do that. She's losing her, loss of fertility. It's also going to put her into menopause. If you take those ovaries and all those hormones. So talking about the hormonal changes and what to expect, and how we call this surgical menopause. We put them into menopause due to surgery. So it's not a really slow, longer process like normal menopause. This is more of a wham bam, you are now in menopause kind of thing. Post-operatively, what do we want to do? We're going to monitor them in the PACU, so their vital signs, their LOC, bleeding, pain. They're probably going to need some antibiotics for a little bit yet. If their ovaries were removed, talk to them about hormone replacement therapy to help with that loss of those hormones. Slowly progress their diet. That Foley should get removed to 12 to, should say 24 hours, not 2. Get them up walking, and then talk to them about discharge education when they do go home. Keep that incision dry. It's normal to have some light vaginal bleeding. About any nutritional information, nothing in the vagina until they're cleared by the doctor, and then also, of course, any signs to report to their provider. This is everything.